Thank you, Dr. Suski, again, for that very informative kind of background as to what's being done in some Latin American countries like Argentina to kind of promote and kind of prevent or actually destigmatize HIV, right? So I want to start thinking about how that might translate to immigrant populations in the United States. So we know that there's certain things that are going on in our home countries to make sure that there's some sort of destigmatization going on, but what happens when they get to the United States? So let's start keeping that at the back of our mind so that we can start addressing some of those things during the discussion portion of the panel. Next, I'd like to introduce Dr. Caffe, which I've already somewhat introduced in the beginning, but to kind of add a little bit to that, I asked her what kind of got her into the field of HIV and AIDS, right? And yeah, I did. And she told me that she realized back in the 90s when she was first getting involved in the cause, she noticed that everything was very heavily fear-based. Images were very fear-based. Everything was about scaring you, to protect yourself. So that really pushed you. Did I get this wrong?
Yes, but my name is Sonja Caffe.
So you don't want me to call you doctor?
No, yes, please. Go ahead.
She doesn't want me to call her doctor.
I wasn't born that way.
Oh, okay, I'm sorry.
No, that's okay.
So, but I'll have you go ahead and, she'll be speaking about Afro-Caribbean experiences with stigma. So.
Thank you, and good afternoon. I would like to start with thanking the very, very kind colleagues from Howard University for inviting us. And when I say us, I mean PAHO, to participate in this important event. It is the timing, we know, is around World AIDS Day, and in fact, this whole week, we have been attending World AIDS Day events from different organizations. In many of these events, it was mentioned that the 2012 UNAIDS report has given us so much hope, because we have, and my apologies if I would repeat things that have been said this morning. I didn't have the opportunity to be here in the morning. But to summarize, the UNAIDS report gave us hope because of it demonstrated the impact we have had as globally, as a global community, on the HIV epidemic. But it also highlighted some of the remaining challenges. And the reason why I would like to commend Howard University is because the echo throughout the different events I attended, and I participated in some panels. We had UNAIDS, we had OAS, we had World Bank, IDB, all of them highlighted the importance of addressing stigma and discrimination. The importance of saying, yes, we have made progress, and at the same time, on the other hand, we see that there are groups that continue to be disproportionately affected by the HIV epidemic, by new infections, and at the same time, we also see that the growth, the acceleration of progress in terms of access to services is not equally divided. And the main crux here is for us to address stigma and discrimination, to ensure that all the progress is equal, that all the subgroups equally benefit from all the resources we have, because we have many more resources than when we started. And I was indeed talking about when I was studying, and I will probably then you will be able to guess my age, but when I was doing my first master's program in the 80s, and I was studying health sciences in the Netherlands, what I remember were these horrific, horrific images of HIV in the 80s, and of people dying, and of everybody going crazy. And at the same time, I was every day in school learning about public health, learning about prevention, and it was very difficult for me to harmonize the hope of public health with the devastation I was seeing in HIV. And I think that drew me very much to work in the area of HIV. And in fact, when we speak about migrant communities, I was a migrant in the Netherlands, part of the Surinamese community I don't even remember how they called us at that time. And my very first professional job was to work on HIV for the Suriname diaspora, and it wasn't just Suriname, actually the Caribbean diaspora in the Netherlands, because we all had elevated levels beyond the levels of the national community. And so I very much sympathize with the whole issue of migrants, immigrants related to HIV and AIDS. And so I will not take a lot of time because I would like for us to have a conversation, but just a few slides. And as I said, I will focus on the Afro-Caribbean community, but many of the things that I will be mentioning, we see echoed in the studies that are being done in the Afro-Caribbean communities in the US, in the Netherlands, in the United Kingdom, and for that matter, in other communities where you have significant numbers of Afro-Caribbean communities. And at the same time, some of these things we also see echoed in other Afro-descendants. There are differences, yes, there are differences, but there are also commonalities that we see between the groups, because some of the challenges of being a migrant, being an immigrant, the groups share. And some of the other things are that the home culture is often taken with you wherever you go, at the deepest, the most fundamental level, even though you might change here and there. And this looks like it's almost not readable. My apologies for that. But I just wanted to repeat, for if it hasn't been repeated, to just kind of put it in a frame, the definitions that I have in mind when I talk about stigma and discrimination. And I just want to call your attention to the red, that we know what stigma is. We know that stigma is just putting a mark on a person or on a group based on a specific characteristic. But discrimination is how you act based upon that mark. And so basically discrimination is enacted stigma. And sometimes we feel very self-righteous when we stigmatize people and we think we don't act on it. We think, well, I'm okay, because in my mind I think, gays are a little bit creepy, but I'm not acting on it, so I'm good. Well, that's not true, because there's a very tiny step between stigma and discrimination. And sometimes, even without knowing, we actually transmit this stigma to others. And so we are still not good if we stigmatize people. And now I'm trying to go to the next slide. And just again, probably a repeat, the UNAIDS definition related to HIV and stigma is really devaluation. And I think that is very important. Stigma and discrimination devaluate individuals, people living with HIV or people associated with HIV. And again, UNAIDS asserts that discrimination follows stigma, and it is unfair and it is unjust. In other words, stigma and discrimination directly affect the rights of all individuals, and as PAHO, we always, our bottom line, and it is also in the preamble to the Constitution of the World Health Organization, we work from a rights perspective. We work from the right to health. And from that perspective, we can never tolerate even stigma and discrimination. And now a little bit, and once again, the framing. We talk a lot about stigma, and I think we were just hearing the thing of self-stigma, but I just wanted to highlight some of the words we throw around when we look at stigma and discrimination, and how all of these are related. We see enacted stigma, we talked about that is discrimination. Anticipated stigma is the fear of stigma. And it might or it might not happen, but there are groups who anticipate that entering into a room, something bad will happen to me. And again, living in the Netherlands, being a person who, when I was born, I was Dutch, actually, because Suriname was a colony of the Netherlands. When I moved to the Netherlands, I realized that being black was a problem. And I began to realize that when I entered into a room, be it at university or at church or wherever, there was a different way of looking at me because I was entering that room. And I had to tell myself, calm down. People, it's their responsibility, it's their problem. Don't begin to anticipate stigma. But of course, it's based on experiences, no? And it builds. And when we look at HIV-related stigma, I think it's very important for us to also look at the whole element of anticipated stigma. Internalized stigma, I think, was already mentioned. That is the self-stigma, and it's mostly based on anticipated or on actual stigma from others. And I think this is very important. We work a lot with health workers, and when we talk about making surfaces more friendly, they say, yes, but the people don't come. And we say, because there is anticipated stigma. So you don't just change your environment and you wait for the people who have been stigmatized forever to come. You have to do this extra step, this extra effort to basically yell in the face, we don't discriminate, please, please, please come. And sometimes we don't do that. I've seen the same working with adolescents, with MSM and other groups. Health workers always complain, we don't discriminate, but people don't come. It's the dynamic between anticipated stigma, internalized stigma, and actual stigma. Secondary stigma by association. When I started the professional work in Suriname, I was also, in addition to working like 100 hours a week, I was also a volunteer to work with terminal patients. And they were all put in a very specific place in the hospital. And even as a compassionate, trained professional, I like to tell people, I'm going to visit the person. I'm not there. Because I didn't want people to think, oh, maybe she has HIV. That is secondary stigma. Sometimes we don't want to associate with a person or a group because we believe it will reflect on who we are and on how people perceive us. Very important, we have had in the Caribbean people who were killed. And strangely enough, a few months ago in Honduras, a colleague of ours was shot in the street. And first we thought it was random violence. But some of the stories that were told appear to be that she was shot because she works in HIV. And it's unbelievable, this day and age, that a group felt so strongly about it that this woman who was 5 months pregnant was shot and killed in the street. I don't have evidence, but that is the rumor that was going around after she passed. And then the last one is compounded stigma, and I think it was discussed already, the layers, where we see that people are being stigmatized because they're gay, because they have HIV, because they are poor, and so layer upon layer of stigma further complicates us effectively addressing stigma and discrimination. Now, we can talk a lot about what the root causes are, but I boiled them down to three things. Fear is a root cause of stigma and discrimination, and we talked about it, the fear of contagion. Sometimes we call it ignorance, but some people, even health workers, are really afraid to deal with a person infected with HIV, thinking that they might contract it somehow. And fear of association, I talked about it. Prejudice and condemnation based on maybe religious, gender, cultural norms and values. And of course, ignorance of the consequences of stigma and discrimination. Again, the difference between stigma and discrimination, where we think it's okay to stigmatize a person or a group as long as we don't kill them, as long as we don't beat them up, because we don't understand the full scope of the effect of stigma, and I call that ignorance. Now, looking a little bit at the Afro-Caribbean communities, and I condensed results of studies that have been done both in the Caribbean and in migrant communities. very, very strong influence of religion. And being in the Caribbean and speaking with people here at the PAHO headquarters, they always say, oh, Caribbean people are so much fun. You always say carnival and stuff. And I'm saying, well, really, we're not having parties all the time. But people think it's fun and carnival and beaches. And they don't realize that right underneath that is a very conservative heart. Very conservative, religious heart, and especially in the Afro-Caribbean community, something that people bring with them. Strong influence of the church. We have seen in countries where the church would speak about sex education curriculum in school and it would be pulled. And the church has very, very strong influence in people's daily lives. Homophobia and heteronormativity. We know heteronormativity is that heterosexuality is the norm. And that is so strong. There's this whole movement now of researching the whole thing of bisexuality and the down low phenomena in Afro-Caribbean men, because the fear, the very strong fear to expose themselves as being gay or as being bisexual, because of this homophobia and heteronormativity, is ingrained. And everything, and indeed in this, all the calypsos, all the carnival culture, they emphasize the whole exchange of men and women and sex and eroticism are all around that. And then, of course, size and connectedness of communities. And I could talk a long time about that, but suffice it to say that really smaller communities have bigger problems. Once again, sometimes my colleagues would say, oh, how you call that rock in the Caribbean Sea again? And they forget the names of the islands. How many people live there again? And they laugh, like, what? 100,000? Ha, ha, ha. And I say, you know, small communities have bigger challenges when it comes to when people really need confidentiality, when people sometimes want anonymity. The connectedness is very good. It's a very good social value and social good. At the same time, it's a real challenge. And we have people picking up the planes to go to other islands to get tested. And I think that is very important once we look at migrant communities where the connectedness becomes even stronger because people want to conserve what they have, where you see that that connectedness becomes a challenge to address stigma and discrimination. And then, of course, the lack of knowledge and awareness. I don't have to speak a lot about that. And just some Caribbean figures, and I'm going to skip that because I think I've been speaking very long already. I just want to share this. I like it, even though I stole it from, this is Sarah Adomako, she does a lot of stigma research in Caribbean communities, just to show that really the research has documented the different levels, the individual impact, the community impact, and the macro level impact that stigma has. And so it gives us tools to speak with politicians to say, listen, it's not just the one person whose wellness is affected, but really we affect productivity. We affect the effectiveness of the HIV response when we do not address stigma and discrimination. Now, what are some of the things that have been done in the Caribbean and in Caribbean communities that really contribute? And I'm sure this morning it was also mentioned that really you need a multi-layered response, but some of the things are creating strategic information. A lot of effort has been put into documenting stigma and discrimination because what you don't document is not there. Legislative and policy reform, even though we all know that much remains to be done, there are very clear steps and very strong advocacy to change all these laws that you were also mentioning of where same-sex between consenting adults is criminalized, etc., etc. Awareness raising, empowerment, and working with affected communities and groups, capacity building of health workers, and of course media and community campaigns, just to keep it on the front burner. And I'm going to just end with this. Also, you had some pictures from Argentina. I end with this one from the Caribbean. I'll read it for you. The guy asked the other one, you negative? And he says, I positive. And he asks him again, huh? You positive? I positive. You positive? You positive? I positive. And he says, I positive that my family and my friends will support me and that the community will be, something like that, will be behind me when I need that. And then he walks away and the other one says, you positive that this will happen, but when? And then it ends with saying, it begins with us, ending stigma and discrimination. Thank you very much.